Today we will continue with the vestibular connections, its functions, dysfunctions and how it is being tested. So the vestibular function test also. So in total we are dealing with the vestibular connections first. So all this will be dealt today. So coming to the vestibular connections, this is actually a special sense which is also having the general rule where these sensations will be passed to the central nervous system. So this is also just like the 3-order neuronal pathway, and the vestibular division or the fibers of the vestibular division that supplies the semicircular organs, canals as well as the utricles and saccular maculae will be together giving rise to a ganglion which is similar to that of the dorsal root ganglion. So we have the vestibular ganglion, which is otherwise also known as the Scarpa's ganglion. So we have the first order neuron, which is the vestibular ganglion, formed by the fibers of the vestibular division of the 8th cranial nerve, and this is actually coming from these receptors. So this forms a first order neuron, and coming to the second order neuron, it is a vestibular nucleus, but here it is the vestibular nuclei because it has 4 divisions, where it is the superior, inferior, medial and lateral. The lateral one is otherwise known as a Dieter's nucleus. So we have 4 groups of nuclei which together constitutes the vestibular nucleus. So this forms a second order neuron, and always it is seen that the medial one and the superior one will be always remaining together, and this is actually seen at the pondomedullary junction because the dorsal root ganglion is always outside. It enters the spinal cord. So here it enters the brainstem at the pondomedullary junction. And then coming to the third order neuron, as in other case it is the thalamus, where again it is a posterolateral nucleus as well as a post-ventrolateral nucleus of the thalamus. But this vestibular nucleus, unlike the rest of the tracts, makes connections with very many other subcortical structures because it has a role of maintaining the posture and equilibrium. So now we will come back to this connections of the vestibular nucleus other than to the thalamus. So in total we have the tracts like the ventriculo-thalamocortical tract or fibers. Then we have coming down, we have the vestibulo-ocular tract or fibers. Next is the vestibulocerebellar tract. Then the vestibulospinal tract. So these are the main connections of the vestibular nucleus. Coming to the vestibulothalamocortical tract, it's actually these fibers from the vestibular nucleus going to the posteroventral and ventrolateral nucleus of the thalamus. From it is projected to the cortex. So which area of the cortex means? It is a temporal lobe, but it is also again from the opposite thalamus, again it goes back to the opposite temporal lobe. But certain books say that it is actually being projected from the thalamus into the which lobe? Temporal. So but it is also said that at times it is being projected into the anterior part of the primary auditory cortex. So to be more specific, in the temporal lobe, it is in the anterior part of the primary auditory cortex because it is actually part of the division of the 8th cranial nerve which has other function of audition. So it becomes a vestibulocochlear nerve. So this is a coming to this, back to the thalamocortical fibers. The function of these fibers are that it is responsible for the conscious awareness of the body position as well as changes or acceleratory forces as well as equilibrium of the body, which is made conscious of by these fibers. Now coming to the vestibulo-ocular tract, this is actually ascending up from the vestibular nuclei along the medial longitudinal bundle. So here it is the temporal lobe. Medial longitudinal bundle, and it synapses with the motor nucleus of the third, fourth and sixth nuclei. That is, the vestibulo-ocular tract rises from the vestibular nuclei and along the medial longitudinal bundle ascends up to synapse with the motor nuclei of the third, fourth and sixth cranial nerves at this level. So this is responsible to give rise to a reflex called as a vestibulo-ocular reflex. We will come to it later. It's very important. Coming to the vestibulocerebellar tract, these fibers, and before that you should understand this is to both sides. The vestibulo-ocular fibers are going to both sides. And the vestibulocerebellar tract is also going to both sides via the inferior cerebellar peduncle to the flocculonodular lobe of the cerebellum to synapse with the fastigious nucleus. The efferent also arise back from the same nucleus to the vestibular nuclei. So we have the vestibulocerebellar tract via the inferior cerebellar peduncle to the flocculonodular lobe of the cerebellum. Again this is bilateral, which means it is going both sides. And this is responsible for the maintenance of the posture and equilibrium. As you know, this is a main function of the flocculonodular lobe of the cerebellum, again for the posture and equilibrium. Coming to the vestibulospinal tract, this is having two divisions. One is the medial and the other one is the lateral vestibulospinal tract. The medial vestibulospinal tract falls short at the level of the cervical region or the upper thoracic region, where it is responsible for controlling the muscles of the upper extremity and the neck muscles. This is short, falling short at the level of the upper thoracic region, innervating the muscles or the nuclei of those nerves which are innervating the muscles of the neck as well as the upper extremities. So those muscles are being controlled by the medial vestibulospinal tract. This is short as well as going only to one side, so it is ipsilateral. Whereas the lateral spinothalamic vestibulospinal tract is long and it falls short at the lumbar level, where it innervates those nuclei which are innervating muscles of the trunk as well as the lower extremities. So those muscles are being controlled and regulated for the maintenance of posture and equilibrium by this lateral vestibulospinal tract, and here it is bilateral. So this is long and bilateral, this is short but going only to one side. So that's the difference. So this will be regulating the muscles of the upper extremity as well as the neck muscles. Here it is regulating the muscles of the lower extremities and the trunk muscles. So that's the vestibulospinal tract. It is said that this tract will all even otherwise making connections with the red nucleus and the reticular fibers before ending with the alpha motor neuron of these nerves supplying the muscles. It may be again either ending directly or through an interneuron. And the facilitatory and inhibitory signals coming from the higher centers will be integrated, and that is how these tracts will be regulating the muscle tone to maintain the posture and equilibrium. That is why these are having connection with both the red nucleus and the reticular fibers, because reticular fibers itself will be of two types, pontine and medullary. One is stimulatory, one is inhibitory. So the balance between the inhibitory and the facilitation will be brought about by the integration and coordination of by this tract on these fibers, and that's how the tone of those muscles or the anti-gravity muscles will be made and posture also maintained. Now coming to this vestibulo-ocular reflex. The vestibulo-ocular reflex is a reflex whereby there will be movements of the eyeballs when there is rotation of the head. So whenever there is a rotation of the head, there will be the movements of the eyeballs in an attempt to fix the image on the center of the retina, or the images will be preserved as such in the visual field without disturbing the vision. So fixing the image at the center of the visual field whenever there is a rotation of the head or movement of the head, will be initiating this reflex. So once the movement of the head is detected, it triggers this vestibulo-ocular reflex in such a way that there will be an inhibitory signal going to the extraocular muscles of one side, whereas there will be an inhibitory signal going to the extraocular muscles of the other side. So one side will be inhibited, the other side will be excited, because already we learnt in the vestibular apparatus, there is a synergistic pairs working together, signals going to the brain will be on one side it is excitatory, the other side it will be inhibitory. So accordingly, whenever there is a movement of the head, it will be detected by the semicircular canals or the utricular and the saccular maculae, whatever it is, depending upon the type of movement that the head produces. At the same time, the signals will be going in such a way that one group of extraocular muscles on one side will be inhibited, the other group of muscles on the other side will be excited. So this is a vestibulo-ocular reflex, and this reflex is normally present in all human beings, and if it is slightly impaired, that will produce very much distress even for reading. And the reflex can also be called as two types, where we have the rotational type of vestibulo-ocular reflex and there is a translational type of. So there are two types of vestibulo-ocular reflex. So whenever the movements are detected by the semicircular canals, that will trigger the rotational type of vestibulo-ocular reflex, and whenever the movements are detected by the maculae of the utricle and the saccule, that will give rise to the translational type of vestibulo-ocular reflex. So whatever be the movements of the head, there is a reflex movement of the eyeballs, because the head can be rotated or moved in its own axis, whether it be vertical, horizontal, rotational. So when the head is moved in any direction in its axis, the eyeballs will also be rotating in its own axis, but in an opposite direction. Followed? So the movement of the head will be associated with the movements of the eyeballs in the opposite direction, and that is a reflex movement produced by the eyeballs, and it is actually a compensatory mechanism whereby the images will be preserved in the center of the retina or in the center of the visual field. So that is the purpose of the vestibulo-ocular reflex, which is normally present in all of us. And that finishes the vestibular connections. Now coming to the functions of the vestibular apparatus, we know there is a semicircular canals as well as the utricular and the saccular maculae. One is acting as a phasic receptor, the other one is acting as a tonic receptor. So the first one, that is a semicircular canal having those receptors, will be actually helping in a what type of equilibrium? Static or dynamic? It is dynamic equilibrium. So let us imagine a person walking or running. Suddenly if somebody calls from the back and he turns ahead, or even if the person hits some obstacle, but still the person will maintain the equilibrium and will not fall off the equilibrium. This is possible because here comes the role of the flocculonodular lobe, which is an organ having a high predictive function, where it can predict the disequilibrium or the displacement that is going to happen, and it will send the signals to the semicircular canals, where it is able to detect at the beginning as well as at the end of the movement, whatever be the type of movement that happens. It can be the angular or the rotational. So that is being detected at the beginning and at the end of this acceleration, and immediately correction will be made by signals being sent to the centers, the vestibular, cerebellar and the reticular. And so here we see that in anticipation of the displacement of the disequilibrium that is going to happen, there will be appropriate adjustments made to the anti-gravity muscles because of this particular mechanism. So all are A, in anticipation, appropriate adjustments against this acceleration, and again it is done in the anti-gravity muscles. So many A's are there. In anticipation, against the acceleration, It is the appropriate changes that happen. It is the adjustments that are made. Adjustments are made in the anti-gravity muscle. So if you remember all these 5 things, that is how the dynamic equilibrium helps us from falling off the equilibrium whenever the person is in motion and loses, and there are chances that he can lose the equilibrium and fall. So that is prevented by the semicircular canals. When it comes to the uticular and the saccular maculae, it is said that it is very much effective in its function, extremely effective, especially when it is in the near vertical position of the head. And we know the direction of these hair cells of the uticular and the saccular maculae are different. One is vertical, the other one is horizontal. So these hair cells will be stimulated in a variable fashion with the variable type of head movements. So when there is a variable stimulation for this type of hair cells to the different type of the movements of the head, the brain will be apprised of the signals going from either side. Again, they are working as synergistic pairs. So here it is not in the same plane, but the same uticular or the saccular macula will be functioning depending upon the acceleration, whether it is in the horizontal or in the vertical direction. So when the signals are being sent to the brain from either side, the brain will be appraised of the signal whereby to which side the head is being moved or the body is being moved to. So what happens is, again, this will be sending signals to the centers like the vestibular, cerebellar, reticular, etc. And again the anti-gravity muscles will be made to have to make the corrections and adjustments, and the equilibrium is maintained. So this helps in actually the static equilibrium. So it just detects the linear changes, but it cannot detect the velocity. That's why this is called as a static equilibrium. So what happens? Because it cannot detect the linear velocity, what happens? It cannot prevent the fall. It only helps in maintaining the balance. So to prevent the fall, semicircular canals will be helping the beginning of the movement and the end of the movement being detected by the semicircular canals. So that helps in the dynamic equilibrium, and this helps in the static equilibrium. That is how this function of the vestibular apparatus goes. Is it clear so far? Now coming to the vestibular dysfunction. Before that, we learned something called as nystagmus. So nystagmus is actually a proper type, another type of vestibulo-ocular reflex. As we know, in all the normal situation, whenever there is a movement of the head, there is a movement of the eyeballs to fix the image on the retina itself, or in the visual field it has to be the proper point. So this is actually an involuntary and spontaneous movement of the eyeballs, again trying to fix the gaze when there is a movement of the head. So it is involuntary and spontaneous, not with a purpose, and this is called as nystagmus. So the nystagmus itself has 2 components. One is a quick component and another one is a slow component. To understand nystagmus further, we will just imagine somebody sitting in front of us, opposite to us, and both of us are traveling in a vehicle. Let us say we are in the direction of the movement of the vehicle in a train, and another person sitting opposite to us. We just observe that person's eyes who is looking out at the objects. So the objects are stationary, but it is moving because we are moving in the train. So this person who is focusing his gaze on a particular point or object, when we are observing, we see that his eyes will be slowly moving as the vehicle is going on in a direction, and the movement will be very slow until at a point where the eyes cannot further be moved. So what happens? At that particular point, the eyes will quickly snap or jump to another point. Again the vehicle is moving, so the movement of the eyes in this particular person will be in a direction which is exactly opposite to the movement of the vehicle or the train. Again it goes to a point, reaches a limit, it again snaps or jumps to another point. So we have seen there are 2 components. The one which is being done as a vehicle is moving on, fixes to a point, it goes on like that and goes to one point, after that it quickly jumps. So that is a quick component. The other one is a slow component. If you observe very carefully, the eyes are actually moving, the slow component is actually moving in the direction opposite to the movement of the vehicle, isn't it? It is in a direction opposite to the movement of the vehicle, which means the person is moving, or instead of the head, now we see that the person himself is moving. The rotation of the eyes are in the direction opposite to the direction of the motion of the vehicle. And when it quickly jumps to another point, it is actually in the direction of the movement of the vehicle. If that person is looking at our eyes, again, it will be the same. If we are looking out, we are looking at an object, and as the train is moving forward, we are in the direction of the vehicle, but our eyes will be moving opposite to the direction of movement. But when it jumps to another point, what happens? It is in the direction of. So always the quick component says in which direction the head is moving. Follow. So the quick component is always giving the direction of movement of the head, if you consider this nystagmus. So nystagmus is something which is not at all harmful, because it can be rotational, it can be congenital, it can be in the vertical direction, it can be a rotational type of nystagmus, anything can be that. It's only spontaneous and it's not disturbing the vision. But the visual process is not affected. Moreover, the vision is not initiating this or triggering the nystagmus. So blind people can also have this nystagmus. So it is not at all impairing the vision. And hence nystagmus at the same time is of help to find out clinically some amount of the vestibular dysfunction. That's why we are just learning about the nystagmus. And it is said that the quick component is always triggered at the brainstem level, whereas a slow component is actually triggered by the vestibular system. So that is nystagmus. And coming to the vestibular dysfunction, we have different types of dysfunction in the case of the vestibular apparatus, where the first one is labyrinthitis, which is the inflammation of the labyrinths. The second one is Meniere's disease. Third one is streptomycin toxicity. Fourth is motion sickness. And this is something following labyrinthectomy. So the labyrinthitis is actually the inflammation of the labyrinth. So here what happens is the person will always be having a symptom. As I told you, whenever there is a dysfunction of the vestibular system, this is actually designed exclusively for maintaining the posture and equilibrium. So whenever there is a disturbance or a dysfunction of the vestibular apparatus, the person becomes highly immobile. It is very much distressing. And it always makes the person feel that he is going on spinning around, even though he is remaining stationary. So that is called as vertigo. So the major symptom in labyrinthine dysfunction is vertigo. And it sometimes said that it can be subjective or objective. Subjective is as a person feels himself as being rotating. Objective is he feels as if the environment is rotating. So that is objective and objective. Anyway, so that is a vertigo, and this is usually associated with nausea, vomiting and dizziness. So that is vertigo. So any person with having a slight dysfunction can have these type of symptoms. Even alcoholism can produce these type of symptoms. That is a vertigo. And motion sickness is also part of this, where the semicircular canals are highly sensitive, and so there is a rhythmic stimulation of the vestibular apparatus depending upon the type of automobile or motion that is happening because of the travel. So it can be sea sickness, air sickness, land sickness, etc. So now this is vertigo, where it is found in connection with labyrinthitis, where we have inflammation of the labyrinth. Coming to Meniere's disease, this is actually due to some abnormality in the endolymph. The secretion is affected, there is some more amount of the endolymph, and the condition results in what is called as endolymph high drops. So there is excess of this fluid, especially in the endolymphatic sac also. So actually tubes of this endolymph is being kept inside for correction. And here the symptom is, or the drawback is that in spite of this vertigo, dizziness, vomiting, etc., there is a progressive deafness, especially the person becomes insensitive to low frequency sounds and it goes in for deafness. So that is a symptom here, especially for the Meniere's disease. And subtomycin toxicity, actually it is an anti-tubercular drug which also produces the same symptom of vertigo. It's a common complaint done by the patients having anti-tubercular treatment with subtomycin. Then motion sickness, again I told you it is a excessive stimulation of the vestibular apparatus when the person is traveling. Imagine a person who is traveling in a ship, especially if the ship is rough. What happens? There are all types of movements that are happening in the anterior, posterior, lateral, as well as up and down. So all the type of movements will be happening in a travel in the ship with a rough sea. So this induces the motion sickness, and it is said that the exact mechanism is actually yet to be understood. So the person will have again all these type of symptoms. It may even be associated with hypertension, BP fall, vomiting, so many other autonomic disturbances. Now coming to labyrinthectomy, if there is a unilateral labyrinthectomy done on one side, in animals we see that the animal will be going on rolling and rolling to catch the balance and the equilibrium. But in human beings, if it is one side that is being labyrinthectomized, the person will get adjusted and adapted in 1 or 2 months. So the person can manage after that. But something which we have to understand here is that whenever a person maintains the equilibrium, there are 4 main signals that help the person to maintain the postural equilibrium. So that includes one is the vestibular, that is actually dealt with in detail in the postural equilibrium. Then we have the visual cues which help the person to maintain the equilibrium. Then we have the proprioceptive impulses. And finally the cutaneous. Let us say the person has had the labyrinthectomy, followed, especially if it is bilateral. And I told you, if the person is blind, at least 2 of these signals, if present, the person can manage. So if he is a blind person with absent labyrinth, he will manage with these 2. Follow. Now we will just imagine a person being asked to walk on a compound wall which is having a sloping top. So a normal person, as he walks on top of the compound wall, what happens? Will he be walking upright or straight? No. So how will he be balancing himself? He will balance himself with a particular posture where so many joints will be bent. Both the upper limb and the lower limbs will be in such a way that he is trying to balance himself, and there the proprioceptive impulses are there to help him to adopt that posture, and that is again helped because the platform is being sensed by the cutaneous receptors, and he can see with the visual cues where the edges of the compound wall can be looked into to protect himself or prevent himself from falling. And above all, we have the vestibular, because whenever there is a motion or a movement that happens, that will be helped by the vestibular apparatus. So now let us see when we make the person blindfold and then make him walk on the same region. So what will be guiding him now if he is made blind? He has the rest of the 3, isn't it? Now we see that he is already having a labyrinthectomy and we make him blindfold. Still, can he walk? Still possible. But when these proprioceptive impulses, as we say, This is actually the impulses coming from the periphery, that is from the muscles, tendons, ligaments, etc. So the nature of those anti-gravity muscles of our body, actually we say that the flexor muscles of the upper arm and the extensors of the lower limb are actually acting as anti-gravity muscles. So the status of these muscles with respect to its tone as well as its state of contraction and relaxation of the different groups of muscles will be variable. So the proprioceptive impulses actually will be variable in the group of anti-gravity muscles to help him maintain the posture, isn't it? So he can manage somehow with the cutaneous. But let us imagine a person who is made to swim in water, in a deep water, who has had the vestibular removed. Now what will happen? Will all the rest help him? What do you say? The cutaneous can help him, but is there any platform where he can feel it? No. The proprioceptive behavior, maximum what he can do is only swimming. But in spite of no platform to rest or find a position where he can maintain, that's also not going to help him. And the visual cues, although not blind, under the water what can he see to guide him? So what will happen? The person will finally drown. So this is why the normal physiological question is being asked about where labyrinthectomized person should not go for deep sea diving. So that is the reason where we say these people should be careful and not go for a deep sea diving or deep water diving. So now we will go to the vestibular function test. Actually, whenever there is some abnormality in the vestibular apparatus or this sense organ, what we do is we can find out if it is normal by inducing a vestibulo-ocular reflex in the form of the nystagmus. So it is being induced by making the person rotate in a Barney's chair. So that is a Barney's test. And the second one is a caloric stimulation test. So what else will be the significance of this test? In addition to finding out whether the labyrinths are functioning normally, we can also find out if there is a brain death. Why? If we rotate the head or move the head, we are supposed to get the vestibulo-ocular reflex. If it is not present, that shows there is a brain death. So these days it becomes important because of the organ transplantation. So we can confirm the brain death that way also. Although that is not the final and confirmatory, we can make use of this test for confirming the brain death also. So here, in addition, clinically, even if we make the person do the Romberg's test. What is that Romberg's test? Asking the person to stand with the feet closed and eyes being closed. So will that person sway or go to fall? A normal person will not. But if there is sensory ataxia due to the lesion in the posterior column, will he be swaying to one side? Because among the four, cutaneous and proprioceptive is gone. Visual cues are gone. So naturally he will sway to one side. But this is not a test for the vestibular function. This is actually a test for sensory ataxia. But this can be positive even in cerebellar dysfunction as well as posterior column dysfunction, but not for the vestibular. So the vestibular function can be done separately in each ear by these tests. So in the Barney's test, what we do is we make the person sit in that chair and rotate the individual at the rate of 10 to 20 per second. So it's very fast. And we look for the nystagmus, the post-rotatory nystagmus. Its direction, rate and duration will be looked for. And then we compare it with the standard and say that whether the person is having some abnormality in the vestibular apparatus. But coming to this caloric stimulation test, which has to be done separately in each ear. Here what is actually done is a person is being seated, and if it is being seated, we will make the person's head being protracted backward for 60 degrees. Whereas if it is in the supine position, we make him flex for about 30 degrees. Because these uticular and the saccular maculae are very sensitive, that even half a degree will be detected normally in the near vertical position. Here we are just making it in this position because we make the vertical canals in the horizontal position and we do the caloric stimulation test. The principle behind this is that we will create a convection current within the endolymph by slightly changing the temperature of the fluid. So we irrigate the external ear with water which is either just above the body temperature or just below the body temperature. So we can use cold water as well as warm water. If it is a cold water that is being used on one side and is being irrigated, stimulating the vestibular apparatus or the semicircular canals, because of the change in temperature that induces stimulation, we see that the nystagmus will be in the opposite direction. So if it is a cold water, nystagmus will be in the opposite direction. And if it is a warm water, it usually produces a stimulus in the, nystagmus in the same direction. So this is the mnemonic which can be used to find out the caloric stimulation test. Whereas the same thing can have another mnemonic which is by ACTH, because away from cold, opposite. Towards the hot, same side. So this is the code which can be used to conclude the test, whether that particular part or the side of the vestibular apparatus is normal or not. If it is abnormal, we cannot perform the test. There will be no response at all. So that's how we conclude. We can also compare with the standard. But all these are become very obsolete because of the development technology. So these tests are only based on these principles where we induce the vestibular reflex in the form of nystagmus, looking for its rate, direction and duration. Because the post-rotated nystagmus will usually be there for 30 to 60 seconds. By that time, we have to detect the nystagmus and then report by comparing with the normal in the case of this Barnes test. Here, it is actually we are looking at the direction, everything based on the type of temperature. So here, cold will be usually done first because that is acting as an inhibitory stimulus, whereas warmth will be acting as an excitatory stimulus. So that is how the vestibular function test can be studied. And technology will show very many newer techniques for detecting the dysfunction or abnormality in the vestibular apparatus. So that we finishes the vestibular function test also. Thank you.